Hello and welcome to JAMA Health Forum Conversations. I'm Dr. Sandro Galea, Dean of the School of Public Health at Washington University and Editor-in-Chief of JAMA Health Forum. Today we discuss aging in America and its implications for health policy, health services, and the long-term care system. The United States is in the midst of historic demographic transformation. By 2030, all baby boomers will be over 65, and for the first time, older adults will outnumber children. By 2050, the population aged 65 and older is projected to reach nearly 90 million. This shift will reshape every dimension of healthcare, from financing and workforce to the models of care we rely on. Nowhere will the consequences be felt more acutely than in long-term care, a system that has been marginalized for decades, exposed during the COVID-19 pandemic, and remains fundamentally underfunded and fragmented. The question is not whether this transformation will challenge us, but whether we can meet it with the policy innovation, investment, and imagination the moment demands. Here to discuss these issues is Dr. David Grabowski, Professor of Healthcare Policy at Harvard Medical School. Dr. Grabowski is one of the nation's leading scholars on the economics of aging, with particular expertise in long-term care and post-acute care. He's a member of National Academy of Medicine and has served on the Medicare Payment Advisory Commission. He served on the CMS Nursing Home Coronavirus Commission during the pandemic. His research, published in New England Journal of Medicine, Health Affairs, JAMA Health Forum, and many other leading journals, has shaped our understanding of nursing home quality, workforce challenges, care fragmentation for dually eligible populations, and the design of payment and delivery models for older adults. He has testified before Congress on 7 occasions, and I'm delighted to be speaking with him today. Dr. Grabowski, David, welcome.
Thank you. It's great to be here.
So let's start with the big picture. The aging of the U.S. population is sometimes described as a slow-moving crisis. You have spent more than 2 decades studying the economics of aging. How do you see the scale of what's coming, and why do you think we have been so slow to prepare for it?
That's a great place to start, and I think you described it perfectly. It is a slow-moving crisis, but I really want to emphasize this is a crisis. It's going to take a lot of dollars and a lot of caregivers to adequately care for all of the older adults. Over the next 15 to 20 years, we're going to have this massive expansion in the long-term care population. And the U.S. as a country is going to need to make a massive investment. I'll just give you one way of sort of scaling this. Everyone always says the baby boomers are coming, but we recently estimated that by 2040, we're going to need an additional 2 million workers in long-term care, even under the most optimistic immigration and labor force participation scenarios. So we need a lot more individuals caring for all of these older adults. So the second part of your question, why have we been so slow to prepare for it? I think both as families here in the US, but also as a society, we tend to put aging out of our mind. We don't want to deal with what's coming. And so I see this all the time. Families, save for college for their kids. They save for retirement. Very few people make preparations for their long-term care years. They don't want to think about that. And we as a society haven't wanted to think about that. So we've tried to address this in a very piecemeal fashion without really making the substantial investments that are necessary to care for all of these older adults that are going to be coming into their long-term care years over the next several decades.
So let's talk about long-term care. So what are the most fundamental structural problems in how we finance and deliver long-term care? And I suppose as a corollary, why have we been so resistant to implement these solutions to these problems?
Yeah, I think the largest structural problems are around the piecemeal way that we finance it and then ultimately deliver it. And so the dominant payer of long-term care services in the U.S. are state Medicaid programs. They're not a very generous payer, and at least historically, they've always been biased towards nursing homes and really haven't offered services for individuals in the home in the community. They haven't allowed individuals to age in place. All of us want care in the community, but all too often we end up having to receive Medicaid services in the nursing home. There's also this problem that you need to qualify for Medicaid. And so we have what I've termed the forgotten middle, individuals that are, quote unquote, too wealthy for Medicaid, yet not wealthy enough to really afford a lot of the long-term care options that are out there in the marketplace. So for those individuals, we're basically asking them to spend down their resources until they qualify for Medicaid and depend heavily on family. And so we put this huge burden on state Medicaid programs, on families, and then on private financing by individuals paying out of pocket. Why is it so hard to reform? Why has this been so resistant? it's really around money. We haven't been willing to make the investment. Long-term care is expensive. I would argue it's quite valuable, and other countries have made this investment, Northern Europe, Asian countries. They have universal long-term care systems. We don't here in the US, and I think that's why we have these fundamental structural problems.
So you've written that the pandemic did not, of course, create this problem, just lifted a veil off it. I think we can argue that's probably true for many other things that were underlying problems. The pandemic lifted a veil. So let's talk about workforce. So you've shown in your work, staffing agency reliance has doubled. Immigrant workers have become essential to sustaining long-term care workforce, and most facilities still fail to meet staffing levels. So what does a actual credible workforce strategy look like, and how realistic are new federal staffing requirements?
As I said earlier, we're going to need a lot of additional workers. We already have a shortfall today, so we're not operating from a position of strength, but rather an existing shortage of workers. It's going to have to be an all hands on deck approach. So first, we're going to need to pay these workers better. Far too many long-term care workers are receiving wages at or near minimum wage levels. It's hard to earn a living wage doing long-term care work. A lot of long-term care workers themselves actually qualify for Medicaid because they're so poorly paid. Many of them don't receive health insurance through their employer. So it's a challenging job to begin with that then isn't properly reimbursed in many instances. So the first part of this is just we need better pay and benefits. Then on top of that, there are other ways that we could make this a better job. And part of that is workplace conditions. We tried in the US to implement minimum staffing standards in nursing homes, for example, to ensure that there's enough workers there, that we're not overburdening workers, and we're providing high quality care for the nursing home residents. Unfortunately, that minimum staffing standard at the federal level was pulled back. So there's ways we could invest in workplace conditions. And then the final piece of this, and there's obviously a long list here, but you mentioned immigration. That's been a key piece of bringing additional workers into the US. We need better pay, better working conditions, but we also need more available workers. We're going to have this demographic imbalance, which is already happening. We need more middle-aged individuals who can help with caregiving, and immigration is a primary way to fill that gap. So I often say that immigration policy is long-term care policy in the sense that we need more workers. And indeed, some of the research we've done recently shows more immigrants into the US leads to more long-term care staff, which ultimately leads to better outcomes. And I'll also highlight during the pandemic, many of the workers that left the nursing home workforce, for example, were native-born workers. Many of the workers that stayed in nursing homes during the pandemic were foreign-born. I like to highlight things were pretty dire during the pandemic in terms of staffing. They would have been that much worse had we not had all these foreign-born workers. Going forward, we need to find ways to expand the pool of available workers.
So at the same time, innovative models of care delivery do exist. I mean, you've studied the greenhouse model, PACE programs, institutional special needs plans. These models integrate care, improve quality, and sometimes align financial incentives. So why do they remain exceptions rather than becoming the norm? What would it take to bring them up to scale?
That's such a great question. When I present on those different models, I often say, why aren't these in place in every community in the country? Yeah, let's take the greenhouse model. So for those listeners that aren't familiar with greenhouse, this is a model that basically turns nursing home care on its head. These are small homes. These are houses basically they can be in a broader nursing home. But basically, it's a home with 8 to 12 older adults living together. It's person-centered. They get up when they want. They go to sleep. They each have their own room. They eat their meals there. And then the workforce, it's a universal work model where the workers are valued, they're well paid. It's much less hierarchical than a typical nursing home. When you go into one of these communities, you immediately see this is a better way to do this care. So to your question, why isn't this every nursing home in the country? It comes down to money.
Hi.
I said earlier, Medicaid is the dominant payer of nursing home services in the US. This model is a bit more expensive. I would argue you get a lot more from this model in terms of quality, but we haven't been willing to make that investment in these small home, person-centered models. But they have tremendous potential. And I think going forward, we're going to have to care for a lot more older adults, but I would argue we have to care for them a lot better. And one of the mechanisms isn't just doing home and community-based care better, it's also doing nursing home care, innovating, as you said, in the delivery of nursing home care. And one of those areas is in models like the greenhouse. Let's implement those. I think the payoff is there in terms of better quality of care and better quality of life.
Let me move to something you've written quite a bit about, which is the dually eligible populations, the fragmentation between Medicare and Medicaid, and you've written quite a bit about how coordination fails this population. So what policy reforms would meaningfully bridge this gap?
This always amazes students when I introduce this topic, that Medicare covers all healthcare services, but long-term care, as we've been discussing, is over here on the side and covered by Medicaid. And so if I'm a dually eligible beneficiary, all my health care is under Medicare, but my long-term care, my nursing home care, my home and community-based care, that's covered by Medicaid. And so it introduces these perverse incentives where state Medicaid programs or the federal Medicare program doesn't invest broadly in outcomes of care. And so I'll just use one of the examples from our research. A nursing home, although they're being reimbursed by Medicaid for the care of that long stay resident, they're not being incentivized to invest in clinical care. And so the resident has to go to the hospital for an issue that should be treatable in the nursing home. But because the nursing home hasn't been incentivized to invest in better clinical care models, we have a hospitalization, which leads to a lot of Medicare costs. And so this sort of cross subsidy from Medicaid to Medicare occurs where we're seeing underinvestment in Medicaid, which ultimately leads to higher spending on the Medicare side. You asked about models here. There are a lot of really innovative integrated care models, the special needs plans, some of which aren't very well integrated, but there are some examples like the fully integrated dual eligible special needs plans. This is a Medicare Advantage plan that encompasses both a Medicare MA plan, a Medicare Advantage plan, but also those Medicaid services. And because it's fully integrated, that means the Medicare Advantage plan has to have a contract with the state Medicaid agency. And so you get this integrated product that hopefully is encouraging good outcomes across the continuum. So we need to invest in these models that break down that barrier between Medicare and Medicaid. I often joke there's two M's in CMS. There's Medicare and Medicaid. And for those dually eligible beneficiaries, these are the individuals who need the most services, who require the greatest coordination of services, yet we often offer them the worst models out there in terms of being very siloed and poorly integrated.
So we talk about long-term care, but most older Americans say they want to age at home, not in an institution. So you recently wrote a really interesting piece examining a proposal to expand Medicare to cover long-term care at home. So what would such a shift mean for the system, and what are the practical challenges to making such a shift?
That kind of shift would be a complete game changer. I said earlier, for many families currently, they want to remain in the community. Nobody wants to go to a nursing home, but they often end up in a nursing home, sometimes just for health reasons and poor functioning. But it's often driven by a lack of social supports, a lack of resources, living arrangement. There's all these other social and economic factors that drive entry into a nursing home. A Medicare benefit like the one that was proposed and I wrote about back in 2024 would be an absolute game changer in terms of introducing services in the community to cover older adults such that they can receive care to age in place without placing a huge burden on their finances, without placing a huge burden on their family caregivers. So I absolutely think that this type of benefit could really sort of reshape how we deliver services. I think the big barrier to making it happen, and I'll come back to what I said earlier, it's financing, it's money. This type of program would add expenditures to our system. On the other hand, I would assert we would get a lot back in terms of making it easier for family members to go back to the workforce, decreasing our unnecessary hospitalizations. There's a range of places where there would be potential benefits, but you can't get around the fact that we're also going to have to pay for it.
So let me ask you a slightly different question, although of course linked to money, about nursing ownership and accountability. So private equity and the challenges of transparency and who actually owns and operates long-term care facilities. You've looked a little bit at this. You've looked at ownership data, ownership quality. So what do we need to understand about the relationship between ownership structure and care quality?
This is a really important point. I'm really glad you raised it. Most long-term care providers, whether they're home care, home health, assisted living, nursing homes, they're for-profit. But under that umbrella of for-profit, we have a huge range of different types of organizational structures. And we have the sort of classic single entity, owner operated, for-profit group that's maybe publicly traded. That type of ownership model is beginning to fade a little bit in long-term care. And more, we're seeing more complex ownership arrangements. You mentioned private equity. We have real estate investment trusts. We have these complicated corporate structures where the dollars aren't always finding their way to care for the long-term care recipients. Unfortunately, in some of these models, we've seen what one group of authors called profit tunneling, where they're taking public dollars from Medicaid or sometimes from Medicare and putting them into other parts of the business, basically pocketing those dollars and not putting them back into staffing, into direct resident care. So I would want listeners to be aware of just the complexity of ownership. This isn't just private equity. Private equity is part of the issue in long-term care, but it's not the whole issue. It's this complex ownership arrangements that are leading to this lack of accountability. We don't know who owns long-term care providers oftentimes, and we don't know how they're spending public dollars. And so any effort to increase that accountability, I think, would go a long way towards beginning to, I think, align all of our goals of improving the performance of the long-term care system.
So we're in a moment of significant fiscal pressure, right, on both Medicare and Medicaid. So CBO projects Medicare spending is roughly going to double over the next decade, driven by what we're talking about, population aging. At the same time, there have been a lot of challenges to Medicaid, which is facing a lot of proposed cuts. So where does that leave us with the fiscal sustainability of caring as the population ages? And where is there room for innovation?
We have some really strong headwinds right now in terms of policy, coupled with the aging baby boom generation. I almost feel like we have two big forces that are about to collide, and we're going to need to care for a lot of older adults, yet we're also going to need to pay for it and figure out how to pay for it. And I think your point about innovation, I would point to three places where maybe we could think about bridging that gap between what we're going to need to pay and just the need to care for all of these individuals. So the first would be, are there ways that we can be more innovative in addressing long-term care needs? And I think this goes beyond long-term care, but we need to invest in innovations that lead to healthier aging. I'm sure there's going to be dementia drugs that are coming online over the next 5 to 10 to 20 years. There's going to be a lot of areas where I think there could be innovation. This is a reason we need to keep investing at the National Institutes on Aging in kind of good research, because I think research is going to help us get to the place we need to be in terms of healthy aging. So one, let's encourage healthy aging. Two, I think we're going to just have to invest more in the workforce, in recruiting individuals into these jobs, paying better wages, coming up, as you said earlier, in terms of more innovative models of bridging Medicare and Medicaid. We can't have long-term care off to the side. It needs to be under the tent. It needs to be a part of the solution. And so let's make sure that long-term care is covered and covered in a way that's coordinated with other healthcare services. And then finally, I'll come back to immigration. We're going to need a lot more workers in the system. We need to pay these workers well, support them, but we just need more workers. And so I do believe immigration as well can be an area to help bridge that gap.
I like the sentence you said, we are facing strong headwinds in the area of policy innovation. I feel like I'm going to make that into a bumper sticker. You've been quite involved in policy translation, right? You've been on MedPAC, you've advised Congress, CMS. So from your vantage point, what are one or two most important policy changes that could meaningfully improve outcomes for older adults in the near term?
I think the first, and we keep coming back to this, but it's so important to me, this disconnect between Medicare and Medicaid. We have so much inefficiency right now in the system around this issue, unnecessary hospitalizations, individuals not being able to age in place, individuals getting unnecessary services. Let's bridge that gap. Let's put everybody on a common footing. And then the second, I would come back to, again, who's going to care for all these older adults? I think we need to make investments in the workforce. And that's not an issue historically that MedPAC, I think, spent a lot of time thinking about. But in more recent years, they really started to focus on it for good reason, because they can see what everyone else can see. We're going to need a lot more workers to care for all these older adults.
So let's end on a positive note. What gives you hope in the moment about the future of long-term care and aging policy in this country?
It's always the people working in this area. Whenever I visit, whether it's a home care setting, assisted living, a nursing home, we have a lot of problems with our systems, but there's a lot of great people doing this work. And that always gives me hope, because I think if given the right system, the right infrastructure, the right kind of incentives, we can do great things. And so there's a lot of people that are very passionate about this work, about fixing the system. And so they give me tremendous hope going forward.
I'm Sandro Galea. I have been talking with Dr. David Grabowski about aging in America and the future of long-term care. Thank you, David, for talking with us.
Yeah, thanks for a great discussion.
Follow us on JAMA Health Forum and the JAMA Network for more conversations on health policy. This episode was produced by Daniel Morrow at the JAMA Network. To hear this and other JAMA Network podcasts, visit us at jamanetworkaudio.com and jamahealthforum.com, or look for JAMA Network wherever you get your podcasts. Thank you for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.